I'd like to introduce you to Julie Siemers. Julie has spent 46 years in nursing, ICU, trauma, flight medicine, academia, leadership, and every chapter of her story points back to one theme. Patient safety isn't just a clinical skill, it's a moral responsibility. In this conversation, she shares the moments that shaped her, like the 90-year-old man in the ICU who had no family to speak for him, and how that experience ignited her life's work in communication and advocacy. Or the decade she spent on a helicopter treating critically ill patients with nothing but her training, her instincts, and the kind of calm you only earn from years of showing up when it matters most. Julie talks candidly about the culture of healthcare, the authority gradients, the missed cues, the preventable harm, and how she transformed those frustrations into solutions. Her book, her patient safety app, and Life Beats Solutions, a training company re-teaching the fundamentals that actually keep patients alive. This episode is about redefining readiness, honoring intuition, and making sure that no patient ever falls through the cracks. This is Shadow Me Next with Dr. Julie Siemers. Dr. Julie Siemers, thank you so much for joining us today on Shadow Me Next. I cannot wait to chat with you.
Thank you for having me. I'm excited to talk to your audience.
I cannot believe that you have been working in nursing for 46 years. Have you enjoyed it? Do you enjoy what you do?
I love it.
Have you felt like you've had moments where you maybe didn't love it so much, or has it just always been a really steady journey up to what you're doing now, which we're going to talk about, and it's just absolutely incredible?
Yeah, I honestly have had times where I thought, I can't do this. And that would just be, I'll give you an example. When I was working in the ICU, moral integrity to me and ethical dilemmas are really a challenge in healthcare in the US, anyway, what I found. I had a 90-year-old little grandpa who had no family, and his body was failing, and he was in the ICU, and the doctors wanted to start him on dialysis. And I'm like, I wanted to say, are you crazy? He's suffering. Why would we extend his suffering? And I wanted to say, too, to that doctor, would you do the same thing if that was your dad?
Right.
So then when you find yourself in those situations, if you can't resolve it, that's what I love about nursing is you can go do something else. Go work in a different department, which I did.
You did. And we're going to talk about that. Absolutely. It's so interesting to me though, because that one story that you've described, it kind of sets the tone for what you have spent recently so much of your time doing, which is improving communication between patients' families and the healthcare team, right? And that was just a perfect example of that man had nobody to speak for him.
Right.
You were able to step into that role, and it just highlights how and why families of patients, people who care about our patients, are so important in that healthcare team model.
Yeah, they truly are because the Joint Commission tells us that 70% of patient harm events are due to communication breakdown. So when we look at the dynamics of communication, as I talked about in my TEDx talk, it's just as much responsibility on the family and the patient and loved ones to create that bridge with the healthcare team to really ensure that the best care is given to that patient. Yes, the families don't have medical knowledge, but they have intimate knowledge of that person and the nuances of, hey, something's not quite right with my mom. We need to explore this and not taking no for an answer.
Absolutely. And in your 46 years working in nursing, I'm sure you have seen, unfortunately, many of those situations. Let's go back. I know your mother was who encouraged you to go into nursing at first, and we can very much thank your mom for the amount of time that you have dedicated to this incredible specialty. And at this point, with your resources, the number of lives you have probably saved because of what you're educating people on. But let's step way back. You worked as a bedside nurse in the ICU, in critical care, and in trauma as well. Those are high stakes, high pressure environments. Can you tell us a little bit, paint a picture for us about what that part of your life looked like?
Yeah, the first 10 years actually in the hospital, I worked in med surg units. So on the oncology unit and the cardiac step down unit. And I know a lot of nurses, when they graduate and have these dreams to go work in critical care, I don't encourage that because the foundation of how to prioritize, how to assess, how to really juggle all the tasks, and not just the tasks, but learn to apply the knowledge, the critical thinking, the clinical judgment is so important. Pardon me. So I did that for 10 years before I ever went into the ICU. And I'm so glad that I did because
Wow.
I had a foundation. I was able to say, something's not quite right here. Dr. Jones, you really need to come and see this patient.
I would like to talk about the team model, and we are going to talk about that, especially when it comes to patients. But in those situations, and I think about our ICU nurses, and you guys are just gods in my book. I mean, the amount of knowledge that you have, the way you advocate for your patients, the things that you see that other members of the healthcare team don't. Did you find that it was always an easy or a productive conversation with the physicians that you were working with, the other members of the healthcare team, or did you run into some challenges there?
Oh, definitely some challenges. We still operate in an authority gradient with the doctor on the top of that pedestal. And don't get me wrong, I admire their dedication and 12 years of medical school
Mm-hmm.
and all that. But when the ego gets in the way of listening, that's when patient harm can happen. When I was teaching at Touro University back in Las Vegas, it was a health sciences university. So we got together twice a year and did interprofessional exercises with all of the schools. So the DOs, the Doctor of Osteopathic students, the BSN students that I was teaching, the PT, physical therapy, the OT. And it was really interesting in doing these exercises. The faculty were monitoring and engaging and whatever. And even in those student days, the DO students still, oh, we had PAs too, which were awesome. The DO students already had started with the bossy, mentality. And I'm like, dude, that nurse is going to cover your butt and
Mm-hmm.
save you, but you can't treat each other like that. The nurses at the bedside, the eyes and the ears, and when they tell you something's wrong, you need to listen.
Yeah,
So it is a
absolutely.
culture. Yeah, a culture that we need to shift.
That's so true. And I think a lot of it has to do with just having conversations like this, right? And stereotypes are valid sometimes, but they're not valid for every single person in every single role. So having that communication open and really talking to the people that you are working with is so important. On the past episode just recently, we talked about even our front desk personnel. For example, if you work in a clinic, that's a patient's first experience. If
Right.
it's soured as soon as they walk in the door, how good do you think your appointment is going to go with them once they get into the room? So it's a machine. It's not a well-oiled machine. It is a machine, and we're going to talk about that machine here in a little bit. But I do want to step back and talk about another machine that you worked on, which is a helicopter. For
Yeah.
10 years, I cannot possibly fathom how number one, how exciting, how thrilling, but also how stressful that was. And you did it for 10 years. Is that correct?
Yeah. And I had enough ER trauma ICU experience to feel pretty comfortable in that role, meaning I felt as prepared as I was ever going to be. But there was definitely situations, what we call the pucker factor.
Oh, yeah.
Because on the helicopter, you might not be able to get a hold of the physician on the radio, number one. We have protocols, but not everybody falls into, the box of here's what you do in this situation. So you had to be able to think really quickly and utilize the skill set that you'd already learned with clinical judgment and application of past experiences. But yeah, what I found is being able to expand my scope of practice was also a challenge because I figured out by now I'm a lifelong learner. And if I feel bored, I need to move on and do something else.
Absolutely, absolutely. Which, yeah, in a helicopter, well, you can't move on to anything. You're stuck in. How big is it? It's quite small, isn't it? Like
The
not even
first one
5 feet
I flew
across.
in was pretty big, and I had some paramedic partners that were 6 foot tall, and that aircraft
Whoa.
accommodated better. And then we eventually moved over into a smaller aircraft. And yeah, you've got your knees, kind of close to you. And we learned that what we had to do on the ground, yes, time is of the essence to get that patient to higher level of care. But when you're on the ground scooping this patient and you don't have an airway and you've got a Glasgow coma scale of 5, 6, 7, 8, you
Mm,
know you need the airway before you get in the air.
hmm
Because the other thing that was a little bit surprising to me is safety first. So all eyes out the window on landing and takeoff. And so it doesn't matter if you're doing CPR, you need to stop and look out the window for any obstacles like wires or, any of those things. Because if that happens, nobody lives.
hmm
And that was an
hmm
adjustment.
Yeah, I would imagine so. It's not often you have to think about the lives of the people that you're working with, not just the person that you're caring for at that moment. So yeah, I
Yeah.
think it's a very interesting branch of medicine, something that a lot of people right now are talking about. And obviously you can have paramedics that are on helicopters. You can have obviously nurses, and I would imagine at some point you've had PAs, maybe doctors work very infrequently on the helicopter with you as well.
Usually it was our medical director that would come do a ride with us because he liked to stay in touch with the reality of what the job was, which I love.
Yeah,
I've always
great
believed
director.
in, yeah, I've always believed in boots on the ground, meaning whatever level of nursing I've ever worked is if you've got leadership that haven't done or aren't in touch with, there's decisions that are made sometimes that aren't in the best interest. And so I try to do that myself, and I really admire people that have that same mindset.
Incredible. You mentioned safety. Obviously, we were talking about hitting wires, but there's something else we definitely need to bring up, and that is the fact that patient harm happens. And this is a really challenging conversation, something that as clinicians, especially, I think all of us, we like to pretend doesn't happen. But as you've already mentioned, happens a lot. And you've said something previously that it's patient harm isn't just tragic, it's systemic. Tell me a little bit about what you've discovered about patient harm and what you're doing to fix it right now.
And I would definitely say preventable.
Good.
Medical mistakes have been quoted out in the literature as the third leading cause of death, which when I started my research back in 2009 for my master's and then my doctoral project, and I discovered that fact, I was shocked. I'd already been a nurse 30 years. So, how did I not know this? And why don't we talk about it? Why isn't it the number one priority for any patient that we're caring for in healthcare? And then I had started peeling back the layers and found it was communication issues, it was diagnostic issues. And then what I actually did my master's thesis and my DNP project on was failure to rescue.
Mm.
Now, even people in healthcare aren't aware of what that is, although it's found in the literature for decades. And it's failing to recognize those early signs of patient deterioration that, again, in the research, they tell us 6 to 24 hours prior to an unplanned cardiac arrest. Now, that is time in my book. It's
hmm
just, I don't believe we've had this cluster, what I call the pillars of patient safety, that we're teaching that nurses and healthcare providers need to look at. And so each of those pillars are vital signs. And it's not just writing down numbers, but what does it actually mean? It's the body telling us something's going on. It's neurological assessment. It's laboratory critical values, it's hydration, both urine output and in, fluids in. So it really isn't rocket science. So when you boil it down to if you as a nurse or healthcare provider would look at these 7 pillars, communication included in there, then we're bound to close that gap of how many patients suffer harm in the healthcare system.
7 things. I mean, when you break it down like that, it doesn't seem astronomical. It's why algorithms work so well in medicine. I think it's
Mhm.
just it is a checklist, but it's more than just a checklist, right? They're actually looking not just at the number, saying, red or green, good or bad. They're using that as part of the rest of these 6 other elements
Yeah.
to make decisions. And then what's the next step? What do they do with that decision? They have to communicate with everybody.
Yeah, the three components of failure to rescue is failure to recognize, failure to act, and then failure to communicate. So when we can close those gaps, and part of the communication, especially for newer nurses, is the fear, like we talked about earlier, of
Mm-hmm.
calling the
Mm-hmm.
doctor. Unfortunately, in some of the schools where I've worked, what we do in simulation lab is kind of berate, as doctors sometimes will do, 2 o'clock in the morning. Okay, if you're telling me the white count's elevated, what's their temperature? And all this data. And the nurse will be like, and then they're totally intimidated.
I'm so glad you brought up SimLab because I had heard you mention this, I think in another episode, and I thought it was so interesting. And it's a part of education that I think a lot of pre-health students don't necessarily realize is even a part of education, or maybe they do and they don't quite know what it's about. Tell me about these simulation labs. Is it just learning how to listen to somebody's heart with a stethoscope, or is it more? And obviously, you've hinted that yes, perhaps we do prepare you for some real world conversations that you're having.
Yeah, so we would grade, we start fundamental with the new students. How, they're intimidated to even have a conversation, which I think is the newer generation. They just really are challenged us with conversations because they're used to texting everything. So, that's the big part of number one, teaching students how to have a conversation. Good morning, Mr. Smith. How are you feeling today? Did you sleep well? How's your pain level? Those basics they really struggle with. But then we advance the scenarios as the students get more learning. They go out to clinicals and they apply what they've learned. But the simulation lab is the first place where they can listen to heart sounds, listen to breath sounds, but really more important, they can pull the pieces together of what's going on with that patient. What's their diagnosis? Are they diabetic? Were they admitted with heart failure? Was their diagnosis pneumonia? And when you have the diagnosis, then you can teach them, okay, if it's pneumonia, what are their breath sounds? How does that compare to what they were earlier or what the previous shift documented? And then it really is the application of knowledge. So, yes, it is. Here's how you stick an IV or place an IV into
Mm-hmm.
a mannequin so you can do it on a real person. But it's like, why are we giving fluids? And are we given the right kinds of fluids? And so it's scenarios that really make them think, and allows them the time to think. Because when they get out there taking care of real patients, some things move very, very quickly
Oh
and they got to
yeah.
be on their toes.
Yeah, yeah. I'm thinking of all of the codes that we learned how to run in PA school, and you're not joking when you say fast. And here's the really interesting thing. If you're listening and you're thinking, well, this sounds extremely stressful, and what do you mean that I have to apply the knowledge that I have and then actually use it to formulate a plan, and then act on that plan? That is what makes us irreplaceable in medicine, is the fact that we are
Exactly.
not robots, right? We have this ability to combine all of these different elements that perhaps are not on the so-called algorithm,
Right.
or we can look at something that a computer might miss and we can say, you know what, I think this part is important, or I have this bit of information that I recall that is definitely applicable here. And that is the human element of medicine, and that is what we are encouraging you to use while you're in school, really to develop first and then to develop the confidence in using. And we're going to talk about confidence because I think you've created a program that combines all of these elements and really gives you the ability to say, I have this tool set, I can use this tool set, I'm going to use this tool set. And that is LifeBeat Solutions. This is a training and development company that you have founded that is focused on transforming how healthcare teams learn, communicate, and protect patients, which is just, I have goosebumps thinking about this. Tell me a little bit more about LifeBeat Solutions and the way that you've seen it succeed.
I developed that. I started with just 10 courses, the two on what is failure to rescue, and then the courses supporting that with the pillars of safety. And I did that because I know as nursing schools, most of them are accelerated, including the one I'm still teaching at or running the school. And there's only so much time the students
Mm-hmm.
can absorb. And there's many times they have to hear things a couple times. When I read several articles over the last couple decades about nurses being safe and prepared for practice, it has fallen from 35% of new grads with a nursing license in 2006 were considered safe and practice ready. And then a decade later, it fell to 23%. And in 2021, it fell to 9%.
What?
So if you couple that new nurses are getting out of school and passing the NCLEX and getting their license, and they aren't ready and prepared for practice, I look at my own, years in nursing, and when I've gone to a new unit or a new place to work, I've always had role models and preceptors
Mm-hmm.
and teachers. Well, nurses aren't staying in the profession anymore. They've got a couple years and they go do something else or they leave the bedside. And so those role models aren't there anymore to teach. So that's why I created, and then it just grew into 35 courses for the fundamentals of clinical judgment, of knowledge application, because I'll tell you, there's research out there too that says new healthcare providers, it's not just nurses, aren't ready for practice. I think the ECRI organization came out with that top number one patient safety concern of the top 10 in 2024 was providers, healthcare providers not being ready for practice. And so
Mm.
that would include, all the other, PAs and DOs and everything too. And one of the top fears of nurses is fear of harming a patient, fear that they won't be able to handle the workload, and
Mm-hmm.
fear that they'll make a mistake and
Mm-hmm.
not keep up with the demands of a 12-hour shift. And so I built these into 1 hour courses where you can take it on your own time. You can pick one that you're not sure about. Let's just say it's vital signs. Why are vital signs important? And learning that respiratory rate is the single most critical, earliest indicator of patient deterioration. And then we learned that 80% of nurses don't even count the respiratory rate because they think it's just a number, but
Mm-hmm.
it isn't. It's the earliest indicator. So, learning things like that, you won't skip and take shortcuts to critical tasks or thinking clinical judgment when you're caring for patients.
Incredible. Julie, who is this course for? Is this just for nurses or does it have benefit for other members of the healthcare team as well?
I slanted it to nurses because that's my background in education, but it really, I think, applies to any healthcare provider that wants to shore up their conceptual and foundational knowledge. For example, I did a 1.5 year stint of selling medical devices, and I had
Mm.
pulse oximetry as well as
Mm-hmm.
capnography. And so those machines apply to any department in the hospital, whether it's NICU or cath lab or ICU or med surge. And I was so surprised at how many nurses didn't really understand the concept of oxygenation versus ventilation,
Mm.
which is why mistakes happen, such as having a patient on a PCA pump after surgery, on a pulse ox, and not counting their respirations. I can't tell you how many stories are out there, and I talk about a couple of them in my book, of not counting respiratory rate and assuming the patient is sleeping because their O2 sats are 97% and they're stable. Well, the
Mm.
CO2 goes up, which then causes lower respiratory rate and eventually apnea. But the nurses really didn't understand, oh, or another example with obstructive sleep apnea is
Mm-hmm.
actually a breathing problem, not a sleep problem. But when you combine opioids with OSA, you've got a critical disaster. And of course, there's stories out there on that too. So, yes, I think it really applies to everyone in the healthcare taking care of patients.
Something that I counsel students on so often, especially in the educational sector, is how what we learn in school and what we see in practice is not always perfectly congruent, right? And that's just standardized testing versus clinical practice. There is a little bit of not a disconnect, but just there's a flexibility there, I think. I'm so glad you mentioned this book because that's where I was going next. And your
Mhm.
book, which is Surviving Your Hospital Stay, that's the title, fantastic title. One of the things I think you're trying to address in your book is that nurses don't even practice what you're teaching in nursing school right now. And this book, which is what makes it so incredible, is not only geared towards nurses and, of course, any member of the healthcare team, but also the patients, the lay people. You're educating everyone on this. Tell us just a little bit more about that, why it's so important.
Yeah, the book came out a couple years ago, and I really was inspired to write it because of having all these patient-family interactions
Hmm.
and knowing that they want to help. They want to be a part of the care team for their loved one. The biggest challenge, I think, is for patients and families learning to speak up because they feel like they don't know anything. They feel like,
Yes.
the doctor's got all this schooling and experience, and the nurse does too. And who am I
Hmm.
to ask questions? But I want to reframe that and say, who are you not to?
Hmm.
Because, in the three stories, I don't believe I included all of those in my book, but the three stories I gave on my TEDx talk was patients and families. The patients were deteriorating and the families did speak up, but part of that was not knowing the chain of command either. So when
Hmm.
you're dismissed by the bedside nurse or the charge nurse, there is that chain of command that you can use. The house supervisor, the chief of medical staff, the hospital administrator who's on call, even holidays, nights, and weekends. And so, really empowering patients and their families to understand even just the basic what is informed consent? Why does the doctor need to initial my right knee if that's where I'm having surgery? All of those things that are foreign, because hospitals are like foreign language, foreign country, right? We even speak that in lingos they don't get.
True.
But to really helping them feel better. And one thing I include in the book too, which I think is most people don't know either, is how to pick the safest hospital in your area.
Hmm.
Go on hospitalsafetygrade.org, put in your zip code, and you can find if the hospital you plan on having surgery at is an A, B, C, D, or F. I can promise you, I will never go to a D or F rated hospital
Mm-mm.
myself.
Mm-mm.
The data shows us that 91% more harm happens in a D or F rated hospital as compared to an A, B, or C. So things like that, tips that I
Wow.
think are just super helpful.
It's an incredible resource, not just for patients, but for clinicians as well. If this is something you're interested in, please definitely check out Dr. Siemers' resources. They are so amazing. I'm so excited to talk about them. You can find them at drjuliesiemers.com. That's DrJuliesiemers.com. She has links to these courses, which are incredible for students, whether you're pre-health, pre-PA, pre-nursing, pre-MD. It at least opens the door to some of these conversations that we're going to have with our healthcare team. Patient safety app for patients and families. How cool is this? And then of course it goes hand in hand with the free patient safety guide. Dr. Siemers, what will we find in these guides and in this app?
I took the chapters in the book and kind of condensed them. They don't have the stories in the app with the learning modules, but they're videos. And they really review the top things you need to know. So for people on the go, it's easy if you're sitting in the waiting room with dad in the ER, you can pull
It's
out,
perfect.
what do I want to learn from this or what would be a good, and there's tons of guides in that book or in the app too. So what are some sample questions of how you should phrase something when you're concerned? The cuss word.
Amazing. Yes, amazing.
Yep. The cuss words, concerned, uncomfortable, scared, or a safety issue. And how can you say that politely, but be persistent in getting your concerns heard?
It's I'm speechless. It is incredible. This gift that you have given patients to be able to utilize their own voice and employ their own knowledge. And like you said, it might not be medical knowledge, but that's not what the nurses and the doctors need. They don't need your medical knowledge. They need your knowledge of this patient, of this person. So absolutely incredible. I will link everything in the show notes below. Dr. Siemers, thank you so much for joining us today on Chat Me Next.
You're so welcome. I hope your audience learned a thing or two that will help them in their journey, whatever that may be. It is a blessing to be able to impact lives, and I will continue that till my last breath.
Amazing. I don't doubt it.